My sincere thanks to the JIS team for this kind invitation to share Jordan's experience with you today. At ESC 2025 in Madrid, we presented two Jordanian cases that clearly showed how our national chest pain MI protocol transforms care, adopting global guidelines into simple, practical steps from home EMS to the ER. وين الله؟ مين هون في من الفنيين؟ Okay. Modern cardiac care today is built on clear practical pathways that help us deliver faster and better treatment. Chest pain protocols, heart failure management, and algorithms for atrial fibrillation, narrow complex and wide complex tachycardia work together to ensure consistent high-quality care for every patient. Supported by the National ACS Registry, this system becomes even stronger through a Center of Excellence model where multidisciplinary teams, cardiologists, emergency physicians, nurses, and allied staff work side by side to provide truly integrated care. With this foundation, let us move into the next slides to see how these principles shape daily practice and enrich the growing GIS regional experience. In the next 6 minutes, I will take you through a real case scenario shown in ESC 2025 that illustrates how unified national ACS protocols improve diagnosis, transfer, and clinical outcomes. The purpose is simple: to show how a structured approach can save minutes and minutes save myocardium. Our patient presented a 48-year-old male patient, diabetic, hypertensive, with sudden persistent chest pain and shortness of breath. At this stage, we immediately follow the national pathway, stabilize ABCs, check blood pressure in both arms, administer oxygen only if saturation is low, and move quickly to the most important early test, ECG, within the next 10 minutes. Our patient presented showed this ECG showed classic features suggestive of myocardial infarction. Depending on your case, this may represent inferior STEMI, posterior MI, or STEMI equivalent. What matters is rapid recognition. Every ECG must be read within the mindset: is this STEMI or STEMI equivalent requiring immediate activation? If inferior STEMI is suspected, we immediately add right-sided leads. If STEMI depression V1, V2 appears, we add posterior leads V7 through V9. This slide, the lower ECG, helps rule in RV infarction. Critical point because nitrates must be avoided. Posterior leads help diagnose a hidden posterior STEMI that is easily missed on standard ECG. This simple step prevents delays in reperfusion. This is the angiography appearance of the culprit lesion. We identify the vessel involved, the degree of stenosis, STEMI flow, thrombus burden. This step determines the PCI strategy and device selection. You look from image A, from image 1 before and after, and image 2 before and after, before application and implementation of the National Jordanian Protocol, and after this step, after wiring the lesion, as you see, and performing balloon dilatation, a stent is deployed. Here you can see the final result: normal flow, no residual stenosis, and full myocardial perfusion restored. That is after applying the protocol. This anatomical change is the visual definition of time is a muscle. You look from image A, left and right, B, left image before angiography, right image after angioplasty. Post-PCI, the focus shifts to medical stabilization, dual antiplatelet therapy, high-intensity statin, beta blocker if not contraindicated, ACE, ARNI, especially with EF reduction, early mobilization with cardiac rehabilitation. Each component is proven to lower recurrent events and mortality. This part is very simple. After we finish treating the patient, we enter the case into the National Registry. Why? Because this is how we make sure every case teaches us something. Just like keeping good notes help a student improve, the registry helps the whole system improve. It shows us how fast we are, how accurate we were, and where we can be even better next time. It is a small step for the doctor, but a big step for the system and quality control. Who fills the registry? The patient was stabilized, discharged on full guideline-directed medical therapy, and scheduled for early follow-up. The key point: following a unified pathway ensures nothing is missed, from ECG to PCI to guideline-directed medical therapy. Who fills it? Data abstractor or registry nurse can do that, the business, or the quality officer. The physician actually only adds brief clinical notes or clarify missing points only. It is not required in the registry from the doctor. This is the time really is a muscle. It is an honor to share Jordan's experience. Our goal is regional integration, Jordan and beyond, to create a unified research-capable cardiovascular emergency network. Thank you all. Thank you.